thanks everybody for joining us today. It's a really exciting opportunity for us to come and talk today and tell you about the IAPT service and what we do and how easy it is to access our service. So I'm really excited and pleased that we could all get together. So thanks very much for joining us. So I'm Nathan Clews. I'm the operational manager for Northampton, the South Northants team within the Change Your Minds IAPT service, and I'm joined by our service lead, Dr. Sarah Clare, who will be taking us through the second half of our talk. If I could have the next slide, please. So today we're here on what's deemed Blue Monday, and I just wanted to make sure that we have some numbers and services available to everybody here to help and support people through which is quite likely to be a difficult time for everybody. And as the presenters have said earlier, it really is okay not to be okay at the moment. So please reach out. We are here. We're here to help as many people as we can. So please don't hold back. Please come and talk to us. Okay, could I have the next slide, please? So what is IAPT? It's not a household name. So improving access to psychological therapies is what it stands for. Could I have the next screen, please? So just a little bit of a background on IAPT, really. Set up in 2008 following a report published to show that there was a huge gap within mental health therapy within the whole country. So in 2008, in Northamptonshire, there were 14 wellbeing workers, as we were called then, employed to join up with the Change Your Minds mental health service, which was in operation then. And we became the Change Your Minds IAPT service at that point. So we were a relatively small team. But since then, we joined up and we worked with our GP colleagues, and we ran clinics from the GP surgeries. And from there, the team has grown substantially, and there's huge growth. We've got over 120 staff members, and we're all trained to offer therapy in an individual basis. We all follow cognitive behavioural therapy, and it's CBT. So because it's such a large team, we've split the team into 3 sections and 3 areas. So the central area will cover our assessments, and the north team will cover Rushden, Wellingborough, Kettering and Corby and all the surrounding areas, and the south team, Northampton, Daventry, Towcester, Brackley and all the surrounding areas there. So it's a large area, really large area, and within that there's a mix of both urban and rural areas, and it can be a challenge at times to make sure we can get to everyone. If we can have the next slide, please. So I just wanted to put into context a little bit about the numbers. So nationally, so the IAPT services nationally will see around about 1 million people per year. So it's a lot of people. And in Northamptonshire last year, around about 12,000 people, with a bump in the road of COVID in there, of course. And at the moment, we're targeted to complete 1,350 assessments per month. Now, that national target of 1 million per year is being pushed to 1.5 million, and therefore there are, we're recruiting 4,500 clinicians nationwide. And in Northamptonshire, we are doing our bit, and we are recruiting as we speak, really. So can I have the next slide, please? So who is it who use the IAPT service? Well, the service is open to anybody who's age 17 and a half and above, and we will be looking for people to support people who are struggling with a range of mental health difficulties, and it's the common mental health difficulties. And as you can see there, depression is one of the main ones that we will cover, but also some of the anxiety disorders as well. And we're looking at the mild to moderate end of things. If people are struggling with a more severe and enduring mental health difficulty, then there are other services within the trust that can help and support them. Can I have the next slide, please? So how does it work? So we take referrals from GPs, any healthcare professionals, but probably the most the easiest way of doing it for a lot of people is the self-referral. So one way is through telephone, and that's our 0300 999 1616 number, and you can get through to our admin team, who will take the details and they will organise a telephone assessment for you. Another really popular way of gaining access to us is using our online referral form, a self-referral form, which is available 24/7, takes around about 2 minutes to complete. And then from there, our admin team will contact you and arrange the telephone assessment for you. So they're very simple ways of getting in contact with us. So what happens at the telephone assessment is our trained staff will complete up to 45-minute telephone assessment. Now, we gather lots of information from that assessment, and then we take all the information and we talk about in supervision with senior staff, and it's just to make sure and ensure that everybody's getting the best possible care. From there, there's a wide variety of treatment options available, and as I said, we all follow the CBT techniques. And what we want to do is make sure that people have the tools that they can use moving forward, and so it's something that they can take and use forever moving forward. So to use those techniques, sometimes we will offer one-to-one support, so a patient will be supported directly one-to-one by one of our therapists. We also offer computerized CBT, and we have a program called Silver Cloud, where people can complete either a module on depression, for example, and the therapist that supports them can complete regular reviews, and they can track activity as well, so we can see exactly how much interaction the patient has had on the online platform. We also run groups. We have quite a program of groups that are running, and they run in a rolling process, and we also run webinars as well. And as I said, everything is based all on CBT, and we look at this in a couple of levels, really. So we have the more mild presentation. People will be seen at the low intensity level, and it may be called step 2. You may hear that as well. Those sessions generally last up to about 30 minutes, and we have between 4 and 6 sessions. The higher intensity is for the more moderate presentation, and those sessions are usually around about up to an hour, and they can be between 12 and 16 sessions generally. And those numbers can be more or less on whatever the need is for the patients. Now, there are some mental health difficulties that will necessitate going straight into the high intensity mode of therapy, and that is all that comes from and is identified at assessment. From the treatment, every session we will complete outcome measures, and these are just quite simple questionnaires that we ask patients to complete each time, and it's to measure mood and anxiety, and it helps also indicate some levels of sort of lifestyle and activity, and it can be used to help sort of just indicate improvements, and we can plot that on graphs, and it's quite a nice visual way of showing people how much they've actually improved. Can I have the next slide, please? So just currently, I know we've had a question regarding wait times as well. So I just wanted the wait time at the moment for an assessment within the IAPT service in Northamptonshire is around about 2 to 3 days. It may even be a little bit less than that. It's really very quick at the moment. So I think that's something that we can really take forward, and it's just shows how easy it is to access us at the moment. We are currently really trying to support our colleagues, and so we're trying to support our colleagues in healthcare as much as possible. So we're prioritising healthcare workers. We are also, the staff are currently going through some particular specialist training to be able to treat people who are struggling with long COVID. So we're trying to look forward and to try and help people as much as possible going forward. And also we've got a long-term conditions team that is just coming on board, and we're currently recruiting into those. So that's a bit of a whistle-stop tour of IAPT and where it began and where we are and how we can access our service. But now we're going to talk about a case study. So that's going to be switching over to Sarah now. So thanks very much, and over to Sarah.
Hello, hi. Yes, just as Nathan says, this is a really good opportunity to get to talk about the support available in Northamptonshire. So thank you very much for tuning in today. So we wanted to give a case study example. So if you can do the next slide, please. So really looking at thinking about, we were focusing a bit more on low mood and depression today. As Nathan said, there'd be people coming in initially for a telephone assessment. So that is a pretty quick stage. I mean, I think sometimes if you phone early, you can even have an on-the-day assessment. I mean, they're very, very quick, and then that would be a 45-minute assessment, and we would be trying to look and pick up certain themes, certain symptoms, and that we might be able to focus on what people are sort of struggling with day to day. So when low mood presents and depression presents, obviously some of the things that we would be thoughtful about is noticing what people were talking about their mood being flat, that they were feeling like they would lost focus, that they were exhibiting signs of sort of self-neglect, not sort of showering, brushing their teeth, or doing the sort of self-care things that they would normally do. In general, actually, we tend to find that people end up doing less, feeling quite tired, quite lethargic, and therefore all of that's become sort of quite a negative cycle. People end up withdrawing from life and the normal activities that they would normally do. That leads to increased isolation, and over time this impacts how people might think about themselves and the world and the community around them. So those are the sorts of things that we would start to look at, and I guess a challenge for us is that during lockdown and during this pandemic, there's almost been enforced isolation in terms of following the rules. Obviously, people trying to ensure, making sure they feel safe, but it's almost put people in the sort of conditions that we wouldn't see as typical as being situations where people would sort of thrive mentally. So we're having to be really thoughtful about people's low mood and thinking about how do we use structure and routine and look at activity to try and sort of mitigate against some of these symptoms that we're finding for depression. The next slide, please. So we're going to assume we've had an assessment, and this is a gentleman who's a 50-year-old male working in the building trade, married with adult children at home. He's got no previous support, and the GP has suggested in this situation that he either self-refers or the GP refers to Change Your Mind's IAPT. Next slide, please. So one of the structures we look at is thinking about some way of thinking about people's symptoms, and we use a CBT, and Nathan mentioned it earlier, as a cognitive behavioural therapy approach, and predominantly throughout the whole service. So within the assessment, we would look at these what we call sort of subsystems, and if you can see by the diagram, this is about how they sort of impact on each other. So we have his thoughts that have been assessed to be: I can't be bothered, I'm useless, what's the point in even trying? In terms of his behaviour, he's not seeing friends, not speaking to his partner, snappier with family, he's stopped all the hobbies and interests, all the normal things that he was doing before. In terms of his bodily sensations, there's no sleeping, increased appetite, muscle tension and a tight chest, and this is having a knock-on effect on his emotions. He's feeling sad, he's feeling down, he's feeling very miserable, worried and stressed. And as you can see from all the arrows, that how we work is that one intervention in any one of these subsets will have a knock-on effect on the other. So we need to think about how we intervene and support this gentleman in a way that's going to be the most effective. And within the IAPT service, we follow what we call NICE guidance, which is based on loads and loads of research in terms of therapy outcomes and models to see what is the most effective way of working with someone. And so we follow that guidance within IAPT to think about how we might step by step working with someone, trying to move them from support with someone with depression. So we can keep those ideas in mind. Next slide, please. So, I mean, this gentleman, as Nathan mentioned, has completed some measures for us. So we have a PHQ-9, that's a depression questionnaire, and that's got a score in this case of 17, which is moderately severe low mood, and the GAD-7 is an anxiety measure, so that's a measure of 8. It's just sort of borderline, that sort of mild anxiety. And how we would approach someone within the assessment within IAPT is thinking about where the level of need is. So the step 2 aspect would be including psychological wellbeing practitioners and senior wellbeing practitioners, and the aim at this point is to try and get some of those, try to reverse some of those sorts of the basics that have gone awry in these cases. So looking at someone's structure, looking at someone's routine. And I think one of the questions has been already around sort of looking at activity levels. And so it might well be that we sort of focus a lot on what people are doing with their day-to-day stuff. You know, how are they looking at the self-care? Are they looking at sleep hygiene, things that we would see as basic drives for sort of taking control and having agency and creating structure and routine for yourself. So we would always look at some of the basics, because it's quite amazing about if you attend to some of that and look at your exercise and look at your eating and looking at some of those sort of very basic things that we do day to day. If we get those right, then actually that often hugely lifts the mood, and that activity level is the first and easier place we start with depression, because it's the easiest way to shift and increase motivation. So activity increases motivation. If you get out on walks, it increases endorphins. All of those things will lift your mood. So that's often the easiest place for us to start. So people will often go in at step 2 to try and get some of those basics. Also in terms of psychoeducation around models and things, so people can get a real good idea about how the depression has developed and what they need to do to combat it in very quick and easy ways, so we can start to try and get people some sense of having some skills. People, that might be enough for a lot of people. Otherwise, people will be what we call stepped up into our step 3 level of care, which is where we have quite a high range of therapy staff there. So we have CBT, but we also have interpersonal therapy, which is a particular counselling model for depression. We have counselling for depression, and we also have more for in terms of sort of PTSD and some of the other anxiety disorders, EMDR. So here alongside, we were talking about depression today, but you would have step 2 for anxiety, a lot of your sort of relaxation, mindfulness, and some I guess some sort of exposure to sort of manage increasing your tolerance or worry, management of certain things that come up. But within the step 3, we're probably looking a little more about therapy, which would be weekly therapy for an hour, looking at sort of OCD, social anxiety, the panic disorders, the more sort of specialist sort of anxiety disorders at that point. So where it would happen in terms of the assessment would be about meeting the needs of the individual. So some people might benefit straight away from step 2. Our waiting times there are pretty much, I mean, I think I did just a sample the other day, and I think everyone had, I think 80% were in a step 2 session within the first 2 weeks from the feedback from the assessment. So we got quite high accessibility at step 2. If we were to do things like the online the sort of online package, which has depression, anxiety, there's a lot of different modules, that's immediate access, and you can even access that before you even have an assessment. So we would try and get some of that skills-based stuff in very, very quickly. If someone hasn't, you know, feels like they need more in terms of after the initial sort of initial work at step 2, then obviously people would be reviewed at step 3 and reassessed at that point, just making sure CBT is the right model, because it might well be that one of the other approaches has come up, or it might well be that through some learning and talking with the client, that it might well be that you know, maybe a different direction is needed. So we always have a refresh and a review, make sure that we're you know, working together with the client, making sure everyone's sort of happy in the direction we're going, and we would review and then access step 3 if that was necessary. So I guess depending, I mean, for this chap in particular, I mean, I think there were lots of stuff, lots of worries and concerns about, you know, dropping all sort of old hobbies and interests and some area around sort of sleep hygiene and things. So these sorts of things would be our first step 2 intervention for this gentleman. And he could access, as Nathan said, that could be in a group if we felt people were quite socially isolated, or individually or online, that would be supported. Next slide, please. And one of the things that we do, what will come up on the assessment, is that someone will ask you about what goals you have. And so we aim this as in a very targeted way, because to be goal focused, to be sort of positive about and very clear about what you're trying to achieve. If we could wave a magic wand and things felt better, what would be looking different in your day-to-day life? And that gives us some targets, and ideally they need to be specific, measurable, achievable, realistic and timely. So we've got a few goals that this gentleman set in his assessment about exercising and speaking to friends and getting into a good sleep pattern. So that lends itself very well to a very quick and focused step 2 piece of work in order to get someone's activities levels up, which we know from experience and from nice guided sort of research that lifts people's mood and gets people's focused. Next slide, please. So we would start at step 2, and I think there's all sorts. I mean, one of the questions has been around, sort of thinking about ideas and how we break this down in terms of activity. Is that we look at routine activity, we look at necessary, obviously there's chores, there's things that we can't get away from, but also pleasurable activities. And what we tend to find in people who have low mood is that they've managed to sort of drill down their life into a very sort of routine and necessary activity. So they're doing the bare minimum of the things that they have to do. And what tends to go, especially through stress, is the things that maybe actually balance some of that out for them. So they stop doing the things that make them feel good or give them time out for themselves. So one of the things we're doing is having a look at the whole stretch of activity over the week. Often see people may not be very activated at all, and look at a graded approach of introducing quite a wide range of routine, pleasurable and necessary activities and building that up over time. And that's going to be at the sort of pace of the person that's sort of making these changes, and in a way that with an individual therapist you can problem solve. So there might well be obstacles or difficulties. There might be as people was suggesting, thinking about sort of long-term health conditions or anything, or childcare, or all sorts of things that we need to balance. So that's why it's individualised to the person to sort of have a look at their particular circumstances, and trying to sort of problem solve and look at how that can be created, because it's important to, I guess, to support the person being able to get permission to do that sometimes. And so we were looking at things like activity levels, we're looking at hobbies, we're looking at past interests, we're looking at things that they do on their own, but maybe some things they might do with others. I know Dr. Smart's going to be talking about this later, so huge passion around sort of walking and exercise and how that can impact on mood. So we're big proponents of that as well. It's important to get outside, use mindfulness, get into the energies, get into the nature, and use the opportunities to exercise both indoor and outdoors. I can't speak now. But also in terms of looking at possible sort of social opportunities, whether that's on social media, connecting into local groups. Some people are volunteering, some people are getting their DIY done. Before they're doing now, so it's looking at trying to look at quite a wide variety of activities that suits people. Some people have dropped things that they used to love and do, playing instruments, cooking, things they've never had time to do with normal circumstances that we're trying to encourage people to do now. So this is something that we might think about with this gentleman around reconnecting with friends, how to speak, maybe express himself with his partner in a way that would feel more positive or more helpful, in a way that he can feel heard. So any obstacles to that we'll be exploring, obviously reintroducing hobbies. Next slide, please. And the more the step 3, I mean, it can be introduced at step 2, some initial introduction to sort of the thought work. But often when we've lifted the mood and people are feeling that feel a bit more motivated, engaged, and the emotional arousal and the distress is sort of removed, sort of at least reduced, we have a lot more opportunity to engage with people and think a little bit about how their thoughts might be also impacting how they're feeling. Are they thinking about things in a certain way, like I'm useless? I mean, it's a very sort of negative label to attach to yourself, and it's very globally very negative. And actually we'll probably find that if we think about it, you wouldn't apply that to anyone else in such global terms. You shouldn't apply that to yourself, and there'll be all sorts of ways that we can start to look at that and unpick that, maybe understand where it's come from, maybe a little bit about, okay, so we understand maybe you were told that for some reason by someone when you were young and you sort of adopted it, but actually we look at you as an adult and the things that you're doing. There'll be all sorts of ways that we can think about how we challenge that. So that's one example of a style of thinking in terms of labelling is the terminology for that one in particular, that we might start to look at and start to unpick. So we look at identifying unhelpful styles of thinking, we challenge thoughts, and we also might otherwise do sort of positive logs as well. Okay, next slide. Just to make you aware, we've been having quite a huge pandemic sort of response. We've been working a lot with the general hospitals, trying to provide some frontline support. Obviously, we've got in some extra staff and some external staff, which is why the wait times are reduced as much to a minimum as we can make them for frontline staff. That's immediate support. We're doing sessions on telephone, on Microsoft Teams. We've been contacting over 65s and people in shielding groups, staff in care homes, doing what we can to try and support our local community and reaching out to lots of different stakeholders, I guess, in terms of trying to think about how we can spread sort of support and make it appropriate to what people need. So, for example, with speaking to GP surgeries today and thinking about how we support staff there, or it might be local communities and areas where we might be thinking about, say, Asher Deep has been one that comes to mind last week. So we're trying to think about how we can work the best with the community. So this is a real passion for us, is a real community working. Next slide, because we do need to move on. So we've put the numbers up. So just in case you didn't get that, the self-referral is the 0300 999 1616, and if you telephone that and say, well, you'll often, if we can't immediately get to the phone, you'll get an answer back within, or a call back within 5-10 minutes, and that's how we sort of register people. People can access that. It's a number that's available. You can self-refer yourself. There's no need to go through GP. Otherwise, there's immediate access to online support through the website that's on the slide. We have fast access to assessment, priority for healthcare workers, and we tailor everything to the individual that comes through. So I hope that helps. So I think, should we go over to questions and answers?
Thanks very much, Sarah. We've had some questions coming through on the chat, and I'll try and cluster some of the questions around a similar topic together in the interests of time. So there's quite a lot of interest in support for long COVID, and I know this is something that is emergent at the moment. We're still working it through, but I don't know whether Nathan or Sarah could say a brief word about long COVID support that we're able to offer. What are our sort of immediate next steps? When might people see something coming available from us? Should we bring Sarah in? I think you're muted, Sarah.
I'm muted, sorry. There is a long COVID response team within the area, and that's a team that we've been liaising with very closely with recently. So I think there's sort of levels and tiers of need, and so people will be referred to the long COVID team through GPs, is my understanding. And then if there's any people that we think that might be specific for IAPT in terms of sort of levels of severity, then we will get referrals direct from the long COVID team. So we've got some specialist training that's been rolled out throughout all of the staff from the IAPT national team, so that's been centrally held. So people are equipped in terms of supporting people with long COVID, but also with things like trauma for sort of spending time in hospitals and ICU. So we've had some specialist training around that.
Okay, thank you. So I've got a couple of questions here about how to access IAPT. So one is a quick one, hopefully. Is the 0300 number free to call?
Yes.
Excellent. That's really good to hear. And another one around services for young people. So we posted some information about our child, adolescent and mental health services in the chat, and there's a link there to the NHFT website which describes a little bit more about the CAMS services and what they do. I don't know whether either Sarah or Nathan are able to comment. I know we've got a session coming up that will talk a little bit more about services available relating to depression, but is there any additional comment that you wish to make at this stage regarding a younger person looking for support with depression?
I think there's quite a number of sort of local support sort of counselling services that that are very good. We often liaise with, but often yes, I mean it's CAMS is our internal NHFT service. We work from 17.5 upwards, and we take some referrals straight from CAMS. But yes, I think it's probably not feeling quite the expert on the child mental health side of things, I'm afraid.
Okay, thanks, Sarah. You mentioned in your presentation prioritisation of healthcare workers. Does this include care home staff?
Yes. We've telephoned all of the care homes across the whole of the county during this pandemic. We did it initially in the very first lockdown. The trust has also done a second round. Psychologists within the trust have done that. So they're very aware of how to refer in, and we have also a staff support. We have a particular team that's just being developed now who's centralising requests that come in from, say, hospitals or GP surgeries or care homes, and then some of that work in terms of support is coming and being centralised from there. I mean, IAPT at the moment is one of sort of the primary agencies going out, but as that develops, I think lots more other staff that have been wanting to volunteer to support are volunteering for that, so that will be spread out across those volunteers within the trust.
Fantastic, thank you. And I think we've got time for one more question before we finish this particular session. So we've got a couple of questions we haven't got around to, but we will provide an answer to those in the chat function. And the question, sorry, back to Sarah again. What would go into a positive log?
It's a positive diary. Sorry, it's our terminology. It's a positive diary. So for example, the I'm useless thought. You might want to go, well, okay, let's have a look at the evidence for. If we were to take that thought to court, how would we weigh that up? And actually, we started to get people to orientate to actually the sorts of things that they were doing. It would be it'd end up being a positive diary, actually demonstrating all the things that they do, because we do things, and it might be that that's been minimised or people aren't paying much attention to it or dissing it. Actually, it's about sometimes even getting a shower, brushing your teeth and starting the day for some people is a mammoth, is a big achievement from where people have started. So I think it's just it's one of those ways of starting to challenge some of those unhelpful styles of thinking that we can all drop into every now and then.